We are chatting to Dr. Oosthuizen. She is a fertility specialist at Cape Fertility Clinic. Last week, we tried to do the video, and she had such a lot of great things to say about PCOS. We were all getting informed, but we had a bit of a technical issue, so we thought, let's do it again. It's a great topic. PCOS is not going anywhere, so let's do it again. And also, we got quite a few of you that said you missed it, so we have listened to you, and we're doing it again. If you have any questions, please put your comment in there. And at the end of the video, Dr. Oosthuizen will give you her email address or just details of where you can reach her. So thank you again for joining us, Dr. Oosthuizen, and we're so glad that you agreed to come on board again. It's over to you.
Thanks so much. I'm sorry to everyone who might have seen it last week who has to listen to me again. So you're going to have to listen to me ramble again. For those who didn't see it, well, let's get cracking, because it's quite a big topic to chat about. And what I chat about isn't rehearsed. There's no sort of order in which I go through stuff. I just want to make sure that you know what I tell my patients when they come to see me. Excuse the theatre hair. I see I'm rocking a bit of a theatre hairdo there. But let's get cracking about ovarian syndrome. So when I talk PCOS, I'm talking polycystic ovarian syndrome. I know a lot of people call it PCOS. My prof who trained me is very against abbreviating it to PCOS, so I will be quite pedantic about saying PCOS for no good reason other than she didn't like it. So I'm going to just start off by saying, why do people with polycystic ovarian syndrome come in and see the gynae? Now, this is obviously a fertility forum, so my focus is going to be on fertility, but there are a couple of reasons why you might come. So you might come because your periods are demarcated. Either the periods aren't coming as frequently, you don't know when they're coming, or when they come for 2, 3, 4 weeks, and this is endless cycle of bleeding. You might be coming because you're trying to fall pregnant and trying to track your period, and you don't know what's going on with period, or you're just not falling pregnant. Or you might come because of the other side of things, which is sometimes acne, or if you have a problem with hair on the body you don't like. Now, we all know when you get a bit older, if we look at our moms and grandmoms, there's a hair on the chin here and there that we don't like. We all seem to start growing a little bit of a moustache as we get a bit older. But if you have hair on the body that you don't like, that bothers you and causes you distress, that is what we constitute problematic hair. And that's another reason why you might go and see the gynae. So there are a whole bunch of different reasons why you might present to the doctor, and those are different reasons that we can address in different topics. So I'm going to focus mainly on fertility and just chat about the fertility side about it. So when it comes to polycystic ovarian syndrome, I do want to just go back to basics, because it helps to understand what we're talking about when we look at the scan and how your doctor is making this diagnosis. And I'm quite uptight about this because so often patients come in and they say, oh, my gynae did a scan, or my GP arranged a scan, and they tell me I've got polycystic ovaries. And I say, based on what? No, just the ultrasound. That is not a diagnosis. That is just one of the features. So you might walk around with the stigma and all these fears, because the minute you Google PCOS, you're going to see all these scary things coming up. And you might walk around with these fears and the stigma to do with PCOS and not actually get the help that you need. And maybe it's not even the correct diagnosis. So it's really important that you know how the diagnosis is made, what's actually going on, because these are not cysts on your ovaries. This is a very bad name that we've given this condition. And then what your options are if you are trying to fall pregnant. And I'll see if I can just briefly touch on some of the other aspects of it, because it's quite a diverse problem. So just a bit of physiology behind it. These are not cysts on your ovaries. What we're seeing when we scan, and the doctor shows you that sort of Swiss cheese look to the ovary. If you just pop into your browser and type ultrasound PCOS ovary, you'll see all these pictures of these ovaries full of all these little black holes on them. Those little black holes are not cysts. Cysts are a very scary word. Cysts are technically 30 millimeters or larger when we scan them on an ultrasound. These are not ovaries full of cysts. You do not need surgery. These are not cancerous. These are not dangerous. All you are looking at on that ultrasound is a whole bunch of little follicles. Now, a follicle is this little round thing in which you grow your little egg every month. Every month in a normal cycle, your body will recruit a whole bunch of these little eggs inside of the follicle, and it will tell all of them to grow. One of those dominates, the others should all fizzle out, and that is the one egg that you would then nurture and ovulate in a normal cycle, presuming you are ovulating. Now, what's happening with polycystic ovarian syndrome is you've got all those little follicles, so potential little eggs waiting to be stimulated, but they're not getting that stimulus to grow and to ovulate. So what we're having is a bit of a funny cycle where you don't really know when you're actually going to have your period because you're not ovulating reliably. So all we are seeing on that ultrasound are those potential eggs that are not doing their job and growing. So it's not a case of you keep recruiting all these eggs and they sit there and they're going to overcluster in the ovary and become a problem. Quite often they will fizzle out after a little while because they haven't got that stimulus. It's just that the ovary is full, chock-a-block full of all of these potential eggs. So that's often what we see when we're doing that ultrasound scan and we're looking for the ovary. Now, all that is a polycystic looking ovary. So the fancy term is polycystic ovarian morphology. That's all that it means. It does not mean you have the syndrome. To have a syndrome, you need to have 2 out of 3 things. Now, this was once very hotly debated and contested. It's now quite well accepted. Something called the Rotterdam criteria. You need 3 different criteria that we have to go through. And if you meet 2 of those 3 criteria, we can label you as having polycystic ovarian syndrome. Yeah. Now, that's important because there's no one test that we can do to make a diagnosis. So I can't do a blood test and a scan and say, there we go, this test is positive, therefore you have polycystic ovarian syndrome. This is a diagnosis of exclusion. Now, what that means is there are a couple of other things that can look exactly like polycystic ovarian syndrome. And if you are not aware of what you are doing as a doctor, you might miss one of those other things. Now, sometimes those things can be treated with other medication. There might be some other serious consequences that we need to know about those conditions. For example, there might be more related to problems we'd watch out for in a pregnancy. So it's important to make sure it's not one of those things. And while we're getting very good at diagnosing polycystic ovarian syndrome, I think we're also getting very lazy about it. And we're just doing a scan, plonking a label on you and sending you off. Yeah. So those 3 things that we're looking for. So I've already told you about the ultrasound, and what your doctor will do is count all those tiny little follicles, and they should show you them all on the ultrasound. If you're not clear what you're looking at, ask them to show you because you need to have this knowledge. Yeah. Have a look at all of them. We'll count them up, and if there's a certain number on both ovaries, or if the ovaries look a certain size, if we have to scan through the tummy if we're a little bit younger and you're not comfortable with vaginal scans, then we can say tick. You've got the ovarian morphology. It looks like it on ultrasound. Then we need one of the other 2 things. So one of those things is that Demarcar period that I told you about. Yeah. And what counts as a regular or an abnormal cycle, so from day 1 of the period to the next day of the period, that is usually a cycle that's between about, some people say 21 days, some people say 24 days. So let's take 21 just to be generous. 21 to 35 days is what is considered a normal cycle once you are in established cycles. And that's something important to differentiate, because there might be moms watching this stressing about their teenage daughter who's just started having her periods and her periods are irregular and, oh, maybe she's got this. Yeah. Remember that it takes quite a while to get into that regular cycle. So those first couple of years, we might say maybe there's polycystic ovarian syndrome, but we don't want to label that diagnosis until it's been about 80 years since the period started. So once you're in your sort of early adult years, 18, 19, 20, then we can start looking at that diagnosis. So if your period is coming less frequently than 21 days, or more frequently than 21 days, or less frequently than 35 days, that's an irregular cycle. If your period is sort of 1 or 2 days out every month, that's not a major problem. A lot of women with polycystic ovarian syndrome will say, actually, I can skip a month, 2 months. I've got some patients who skip 3, 4, 5 months without having a period, but you don't have to be that severe to meet the criteria. So Demarcar period, ultrasound findings, and the third thing is signs of increased testosterones, what we call the androgens. Now, every woman needs to have androgen. It does not make you a man. It doesn't make you masculine. If you didn't have androgens, there would be a problem. And that's some of the horrible symptoms of the menopause is because you stop making so many androgens. So when we're looking at the androgen levels, we've got 2 ways we assess it. Number 1, when I look at you as a patient, are there signs that you have androgen problems? Now, the most common ones are acne, hair on the body you don't like, so breasts, sometimes the tummy, sometimes it might be more on the arms and the leg, and there's a specific score that your doctor will do for you. But if you're complaining about hair, remember to tell your doctor if you wax, if you laser, if you bleach, because otherwise we might miss hair that actually is a problem. Acne is obviously a very common one. Some of the more severe signs that we don't really expect are things like increased hair loss on the head. Sometimes you might struggle androgens having a bit too much of a sex drive, sometimes a change in the voice, but that's usually a result of very high androgen testosterone levels, and we're usually looking for something else, not polycystic ovarian syndrome. So it's usually mainly to do with acne and hair that you don't like.
Yeah.
So if I can't find those on you and I'm looking for signs of increased androgens, I can do your blood tests, and we can measure all the different little androgens that we would look for. If those are up, then we can say, yes, there are biochemical signs. So on your blood test, there is signs of increased androgens. Then you would have 2 of those 3. So ultrasound, the androgens, either clinically or on the blood test, and the DMRCAR periods.
Yeah.
But remember the one caveat, and like I said, there's no one test you do for polycystic ovarian syndrome, is it can't be caused by something else. Now, there are a few other conditions. They're not that common, but they do exist. I've seen a patient recently, as recent as 2 days ago, with one of these other conditions, I'm quite sure, who's been labeled as PCOS, and it's very clear when you see her that that's not the case. So there are 1 or 2 other blood tests we do to exclude those things, and it's very important that your doctor doesn't skip that step. No matter how clear-cut PCOS patient you might appear to that doctor, be sure it's none of those things. They might ask you to do some of these things, such as your cortisol levels. They might ask you to check for a special kind of hormone called 17-OHP, but this is all to identify other conditions that can look exactly like PCOS.
Okay.
Now, the other set of things that we might do are the sort of ugly friends that PCOS likes to hang around with. So a lot of the time, if you're Googling PCOS, you're going to hear about weight issues. You're going to hear about metabolic conditions. So whether it's going into diabetes type 2, whether it's getting insulin problems, cholesterol, high blood pressure, struggling with your weight. So those are all the bad influences, the really naughty friends that PCOS likes to bring with it. And that might not be your fault because you have this condition, but there's stuff that you can do to try and improve it. So that's the really positive part of it. So what your doctor should be doing is making sure we don't have a blood pressure problem, making sure that your weight is okay, checking your BMI, checking your cholesterol, which is a fasting test, checking your sugar, and checking your insulin levels. So those are sort of the standard things that we do to make sure there's no metabolic thing in the background. And you might be thinking, okay, but I just want to have a baby. Why do I care if my cholesterol is up or if I become diabetic? Well, we care because if you become pregnant at a higher weight, if you are overweight or cholesterol problems, blood pressure problems, you're setting yourself up for a disaster over pregnancy. Remember, pregnancy amplifies underlying problems quite often. So if you start off with a bit of blood pressure, it might get worse if we're not careful. If you start off with a bit of insulin resistance, it might become full-blown diabetes. The other thing that people don't like to talk about, and they get a bit upset when their doctors mention it, is the issue of weight and being overweight. That's always the elephant in the room. No one really wants to address it because we know it's upsetting. And we know the frustrations of trying to lose weight. And it's really important to understand why we want you to lose weight. And like I said, going into a pregnancy from a healthy point of view. Number 2, if I'm trying to make you ovulate, if that's the main issue with polycystic ovarian syndrome, you're not ovulating. I'm giving you medication to make you ovulate. That medication is more effective at a lower weight than a higher weight. You're more likely to fall pregnant. You're more likely to take home a baby. You're more likely to have a healthy pregnancy and less likely to have a miscarriage. So this is not me being pedantic, being difficult, being judgmental when I say I need you to lose weight. This is me looking after your health, your success, your take-home baby. Okay. Yeah. And I mentioned last week that there is a dietitian that I recommend. She works with an endocrinologist here at our center. She does do Skype consultations. So anyone who's not in Cape Town who wants to meet up with her, I will share her details. She has phenomenal with every patient I have sent her. Every patient I've sent has said, I've tried to lose weight. I can't. It comes off 2-3 kilos and then it bounces back. I can't make it work with my lifestyle. And so far, she has not let me down. Every single patient has come back losing somewhere between 5 and 20 kilos. I've got a patient who dropped 20 kilos in probably about a month, and with very subtle changes. And I'm on this diet now as well. I'm trying to drop a few kilos before I get married. So I can also say I'm doing the diet and it is easy. It is not difficult to do. So I'm more than happy to share her details. I'm a big fan of what she does. So finding a dietitian who understands why you eat the way you do eat and trying to alter all the metabolic parts of your life, especially the background of polycystic ovarian syndrome. She is excellent. I'll share her details.
Thank you.
So now we understand why you've got this diagnosis. How did your doctor come to this diagnosis? How did we make sure it's nothing else? And we understand that the problem is most likely that you are not ovulating. It's still important to see a fertility specialist because there might be something else wrong. Just the same as if you have high blood pressure, it doesn't mean you can't have diabetes. You can be not ovulating. It doesn't mean that there isn't a problem with the sperm or there isn't a problem with the tubes. So it's always important to have that assessment to make sure the only thing we're trying to overcome is the fact that you're not ovulating. So when we do that assessment, we'll do scans, we'll do some of these tests, we'll make the diagnosis, we'll check your partner's sperm, we'll make sure we don't think we need to check the tubes. And if we're happy it is just an ovulation thing from polycystic ovarian syndrome, we're going to make you ovulate. Now, that's where a bit of the science comes in. We've got different ways that we can make you ovulate. I'm going to run through all of those for you. Just bear with me. So we've got the tablet forms, we've got the injections, we've got the surgery, and as a last resort, we have IVF. So when it comes to trying to make you ovulate, there's a big difference between you with polycystic ovarian syndrome and another couple who regularly ovulate, who are having intercourse at home and not falling pregnant. The big difference here is we're trying to get you to ovulate even one egg. With those couples, we're trying to get them to ovulate more than one egg to increase their chances of being pregnant. If your main problem is that you don't ovulate, one egg is already 100% improvement from where we were. So a couple of medications, and this has been something there's been a lot of research on and a lot of data on. There's a first-line drug that we should be preferring, and that fancy name is Letrozole. You might know it as Femara. So most clinics will dispense it. There was a bit of drama about it right back in the beginning, saying it might be linked to heart problems in babies. We have no evidence of that, and it is used non-stop by majority of clinics. So we are not.
Sorry, can I just say something quickly before you go on? Our messages are coming through. There's so many messages coming through, questions. So I just want to let everyone know we are seeing your questions, and as soon as doctors finish speaking, she will answer some of the questions for you. So hang in there, ladies. Let's first listen to what doctor has to say. Thank you. You can go in.
And if you don't feel I've answered your question, I'm more than happy for you to email me. So
okay, thank you.
Okay, let's get back into how we make you ovulate. So Femara tablets, what we usually do is we time it to a cycle. So day 3 of your period, we will start you on tablets. We can start up to day 5. So if your doctor started you on day 5, that's not a problem. Day 3 to day 5. So what happens if you don't have a period? How do we know when day 3 is? Well, we can make you have a period. We can give you some of those Prevera tablets, which most women who've had polycystic ovarian syndrome diagnosed would have been given at some point. Yeah. Those are just progesterone tablets. You take them for usually about 10 days to 12 days. If you've been giving them for a shorter period of time, they're probably not going to work that well. Those tablets, and this is really important, I get asked this all the time, Prevera, progesterone does not make you ovulate. It will not help you fall pregnant. So if your doctor has given that to you, it's to keep your cycle regular. Okay. So we might give them to make you bleed. From day 3 to day 5 of your cycle, we'll start you on some tablets. First choice should be Letrozole or the Femara tablets. You usually take them for 5 days. There's a variety of doses. We usually start off quite low, and we can build up the dose. Some clinics might start at a higher dose. It's very independent on what your doctor wants to do, what they think is going to happen with your ovaries. So we would then call you in for a scan, usually about day 10 to day 12 of your cycle. And we're going to scan and measure that follicle. Remember, that follicle is a little egg factory. Now, we can't see an egg on ultrasound, but hopefully if the medicine has done its job, we're going to see a nice big fat follicle that when we measure is somewhere around 17, 18 millimeters in size. If that's the case, then we know we've got a little egg, or we should have a little egg inside there that's ready to be ovulated. Then we will give you an injection that we teach you how to do at home. You can take that injection. It would make you ovulate in roughly 36 hours, and we can time when to have intercourse. So that is called ovulation induction timed intercourse. So there are no samples being put inside of the uterus, anything like that. It's the DIY option, but once we know that you have ovulated. Yeah. Some doctors might make you ovulate with an injection. They might ask you just to keep testing your urine with those LH strips. We're not too much of a fan of that. We don't mind if you naturally ovulate, but those little LH sticks can actually get quite emotionally destructive when you're checking the morning, night,
Yeah,
and this
yeah,
is going
yeah.
on for a couple of days. It can be quite tricky. So it's a lot easier just to make sure you are ovulating by giving you that injection. So that first scan is important because we want to see, is that follicle there and is it big enough for us to trigger? Because not every woman is the same. Now, I might give you one dose and you make a beautiful follicle. The next patient might not make a follicle. So I might need to give her a bit more time, or I might need to change my approach. So it's never a reason to panic if that first scan does not show you a follicle. Your doctor has a plan B to follow on to that. The other important thing is we want to know how many follicles there are. And this is where we really like Femara, because it tends to give you one follicle. Now, everyone who's been trying to have a baby wants twins. I hear this all the time. Well, we've tried for so long, 2 won't be a problem. We don't necessarily like twins because it is a high risk pregnancy. That is risky for you. It is risky for your babies. And it sounds like a very sweet idea to have your pigeon pair and, you know, one and done, have your 2 babies. But it's not that much fun when you're lying in hospital at 22 weeks with complications from a twin pregnancy. So we prefer safe, healthy pregnancies that result in take-home healthy babies. And that tends to be more likely with a single pregnancy. That's why we like Femara. It usually gives us 1 follicle. So it is far more likely to give us 1 baby rather than 2. Number 2, it has far less side effects than Clomid. So I'm going to chat a bit about Clomid, but I'm sure most of you have heard of Clomid before. It's a really famous drug for making you ovulate. So the nice thing about Femara also is we have the data that tells us you are more likely to ovulate with Femara, with polycystic ovarian syndrome, than Clomid. You are more likely to be pregnant and you are more likely to take home a baby compared to Clomid. So that's why it is our first choice. Second choice, or if you don't have access to Femara, is Clomid. Now that again is the same thing. We're going to make you have a period, start you on the tablets between day 3 to 5, 5 days of tablets, scan day 11. We go through the same process. You are just more likely to make more follicles with Clomid, which, like I said, we're not that much of a fan of. So how many follicles is a problem? Most clinics would say more than 3 is a problem. Your risk of twins or triplets, and we usually just say multiple pregnancies with either of these drugs, is between about 3 and 8%, so it's not very high. But if you told me I had an 8% chance of winning the lottery, I would go and buy a hell of a lot of tickets. Yeah. So it might sound very little, but it is significant from that point of view. So Clomid has side effects. It might give you hot flushes, dizziness, headaches. So people tend to complain a little bit more about it than the Femara, but it is also very effective at making you grow nice big follicles. Again, we're going to check the size of them. We're going to make you ovulate them. But if there are more than 3, your doctor is going to say, please do not have intercourse. This is too dangerous, and not do the cycle that month. Then the third option that's out there from a tablet point of view, and I don't really like to compare this so much to Femara or Clomid, but I get asked about it a lot, is Metformin. So you might know Metformin by glucophage. It is usually used to drop insulin levels. Now, it's one thing if your doctors prescribe that for you because you are a type 2 diabetic or because your insulin levels are very high and we want to drop them down. It's a completely different thing to be told you need Metformin just to make you ovulate. Now, when we took the big studies, took a group of women on Metformin, a group of women who weren't given Metformin with polycystic ovarian syndrome, you were more likely to ovulate with Metformin than with nothing. But if you compare it to the other drugs, it can't compare. They will always be better. So Clomid and Femara will always be better than Metformin. The whole thing about Metformin is you are probably going to ovulate 1 follicle because it's not inducing that ovulation process. It's just taking away that insulin interference in the ovary. So if you have a patient who says, I just cannot get to you for scans, I live 2.5 hours away from the clinic, no one can monitor me, I can't do this safely at home, Metformin is better than nothing. But it is never going to compare to Femara and to Clomid. But the last option from a medication point of view are injections. And I've got my trusty little injection over here. So some of you might know these guys. It's called Gonal F. It's usually the one we use. Sometimes you might use a different formulation, one of the Menopures, which is a powder and a water. But these are the ones that we like to teach you how to use. They come in little pre-filled things. We teach you how to set doses at the end, and these are really not bad injections. The minute you say injection, everybody freaks out, but these needles are teensy tiny. They're smaller than insulin needles. They really don't hurt at all when going in, and I can tell you this because I've tried these, so they're definitely not sore. So what we can do if we are struggling with the other medication, or if we think the other medication isn't giving us good enough response, we can consider using these gonadotrophins. So the catch with these injections is you're going to inject yourself every day. So number one, it's a lot more cumbersome than taking a pill for 5 days. Number two, these are quite expensive. And this is not fertility companies trying to make money. We generally sell these at what we pay to get them. So it's just unfortunate that these drugs are expensive. So if you're going to use one of these pens, we usually start off at a very low dose and we slowly increase the dose until we can see the ovaries are responding and giving us a follicle. Then we might pull back a little bit on the dose. There are a couple of different ways that we can do it, and every doctor might approach it slightly differently. But you are going to be on these injections for quite a while. So probably, I mean, in my experience, I haven't seen someone grow a nice big follicle in less than 10 days of injecting on these. I've had patients that have taken 3 weeks worth of injecting to get to that follicle. So if you can imagine 3 weeks of these, it's expensive, it's long, it's a lot of scans. So it's not our favorite way of doing things, but it is very effective. Okay. The other catch is with these, you might make a lot of follicles. So if you make 1, 2, or 3 follicles, okay, we're sitting with a risk of a multiple pregnancy, which is 3 times higher than with the tablets. So it is a significant risk. And when I say multiple, remember, that could be twins, that could be triplets, and that's a very complicated pregnancy. So the multiple pregnancy risk is a drawback from this one. Plus, what happens if you make 5 or 6 follicles in the end? You're going to have to either convert to IVF or, again, sit out the cycle. And that's not really fun when it's taking you 2 weeks of injections to get to that point. Yeah. So your injections should not be done by a general gynae. They should be done by a fertility specialist who has experience in how to do them. I think we all get a little bit big breath before we have to start one of those cycles because we know it's going to be a bit longer and a bit more finicky. So if you are up for that and you understand the cost implication, the time implication, then that's completely fine. So that's the medication approach. Tablets, injections, and you might want to combine it with insemination. That's a topic that Dr. Matabesi has previously discussed if you need it for a male factor, for example, or if you're using sperm. Then the other option is obviously IVF, and again, that comes with the injections, and I can chat a little bit about that, but first I just want to chat about ovarian drilling. Now, ovarian drilling is a surgical approach to the polycystic ovary that doesn't want to ovulate. It's usually not our first choice, just because it's a surgery. You've got the risks to do with the surgery, which is the anesthetic, the infection, the fact that it's really invasive. You're going to a hospital in the middle of a pandemic. That's obviously not great stuff. The risks to the other organs where we're working, bleeding, infection, all that sort of thing. Obviously, we do these surgeries every single day, and they are generally safe, but you've got to weigh up medical option that might be safer versus a surgical intervention. So it's usually not first line unless we say, hold on, there's something else going on. We want to look inside the tummy. So maybe you have very bad period pain, or maybe we want to check the tubes, or we think there's endometriosis, or there's something else going on inside the tummy, and we have to do a surgery anyway, then maybe we should consider ovarian drilling. Now, what we would actually do is take a really hot little, sounds like a needle, or we call it a monopolar needle, but actually it's just a form of energy in this little rod. And we actually stick it into the ovary at several points, and we burn little areas of the ovary. And what we're trying to destroy is actually that little middle bit of the ovary that makes all those androgens, the testosterones, because we know that when we do a little bit of damage to that, we might increase your chances of ovulation. And we've seen that it's as effective as these injections are getting you to ovulate.
I've had it done twice, and I've actually felt conceived with one of them. Unfortunately, it was a miscarriage, but I've conceived with one of them.
So you know that it does work.
Yeah.
That's the bottom line. But obviously it does come with that whole intervention, the cost to do with surgery.
Yeah.
So from that point of view, the one downside of it is that we're using energy inside of your tummy. We might leave some scar tissue in there. Other than the other potential injuries that can happen, and we will drop your ovarian reserve. I cannot stick a hot piece of metal into your ovary and burn it and not to damage that ovary. So we will drop your ovarian reserve. So it's not a great option for people who have polycystic ovarian syndrome that might be a bit older with a lower ovarian reserve that you don't want to mess with too much. It also doesn't guarantee you won't need other medication, because a lot of the time you still might need to use other medication. It just makes it more likely that medication will actually work. So the patient who's not winning with Femara or not winning with Clomid, and we're getting really frustrated because I can't get you to ovulate, the ovarian drilling might make that work. So that's when it becomes a very handy option from that point of view. But it does not mean you will start ovulating perfectly every single time. And it does come with those little risks. So we always say that the ovulation induction is our first line. Unless you really need to do the surgery, then you might consider doing some drilling. Second line would be these injections, or equally so the consideration to doing ovarian drilling. Now, IVF is obviously not what everyone wants to sign up for when you start talking about fertility treatments. But if we are really struggling to get you to ovulate, IVF actually might be a good option. Sometimes the other reasons you might need IVF, maybe your partner's sperm count is quite low, or the motility is low, maybe the tubes are damaged. There might be something else related to that. So IVF can also be an option for you. We just need to be very careful when we stimulate you. And the reason being, we're so full of all these little potential eggs that when we touch you with the smallest dose of this medication, we tend to stimulate a lot of those. And what we don't really want is a situation where your ovaries are producing a lot of eggs. And by a lot of eggs, we usually say 15 or more. It's quite a lot. And that's where we start getting worried about something called ovarian hyperstimulation, which is quite dangerous. It can put you in hospital. You can have fluid shifts in the body to your lungs getting full of fluid, your tummy full of fluid, the ovaries massive and swollen, the kidneys can take strain, you can get blood clots. It's a very dangerous condition. So if you're going to do IVF, your doctor will personalize the medication that you get so that it is very low dose. They will choose a different kind of trigger in the IVF cycle to try and prevent you getting hyperstimulation, and they might choose to not transfer an embryo in that first cycle just to try and avoid the hyperstimulation. But the reason that IVF is a little bit easier to do than just these injections to make you ovulate 1 egg or 2 eggs is because I'm trying to get you to make a bunch of eggs. So I can be a little bit more liberal. I'm not trying to give you enough to get that egg to grow, but pull back so that you don't get too many growing. I get to be a bit more and trying to get a couple of them to grow. So IVF is always going to be one of our greatest success options when it comes to fertility treatment in general. You might need it for other reasons, but we are always very cautious. And as a patient who has polycystic ovarian syndrome, ask your doctor about hyperstimulation and what their strategy is to avoid it, because you have the right to know about that. So in terms of the whole fertility issue, people are often coming to us and saying, I want to be pregnant, but I'm also miserable about my acne and the hair on my body that I don't like. The catch with dealing with that stuff is we can, and we are the perfect people to help you deal with this. You don't need to go and see a dermatologist necessarily for it. But the catch is the drugs we would use to help you, number one, take time. They don't work overnight. So if you have hair that you don't like, it's going to take 6 months for you to see a difference. And I can't make it better than what that is. Also with the acne, it's going to take a couple of months to see a difference. But the problem is I cannot treat those two things and try and get you pregnant. The reason being, one of the first options is a contraceptive, and that's not rocket science. I can't stop you falling pregnant and get you pregnant at the same time. The second part of the treatment that we might add in are what we call the anti-androgens, so things that drop your testosterone levels. Now, that might sound like a great idea, and you don't really need testosterone, so why would that be a problem? Well, it's a problem because if you have a male baby, you are pregnant with a little boy baby who is relying on his testosterone, and I'm giving you anti-androgens, that boy might come out looking like a girl, and that's not something we want to do intentionally. If we are treating your acne and we are treating the hair medically, then we cannot do that at the same time as trying to get you pregnant. Once you've had your baby, you want some help with that, then we help you. So we tackle those things individually. But don't underestimate what losing weight and getting your insulin down can do for acne and what it can do for hair on the body you don't like. Obviously, there's always laser as an option. There are some creams that we can prescribe. And there are a couple other treatments like Gractan, that kind of thing for acne. But again, you can't use that while you're trying to fall pregnant. So I feel like I've had a bit of verbal diarrhea on this topic. So I don't know if you really go into some of the questions, if there's anything people want more clarity on, or you feel I haven't covered well enough.
Yes. So I was just actually just looking at all the questions. So I've got so I've got Jamie asking, I have PCOS, type 1 diabetes, and have a BMI of 25.7. I want glucophage and insulin. How does my diabetes affect my PCOS? Could my PCOS be affected by my insulin injections?
So that's a little bit of a different thing. So when we're talking about PCOS and diabetes, what we're talking about is type 2 diabetes that comes from insulin resistance. So if you're a type 1 diabetic, that usually means it started off when you were a lot younger. So you were usually a teenager, or sort of, around about 10, 11, 12 when it started. Sometimes it can start a little bit later. There's a differentiation between type 1 and type 2, and type 1 starts a lot younger, and that's not really so much related to polycystic ovarian syndrome.
Yeah, she says type 1, sorry, it's type 1 diabetes, yeah.
So the important thing to remember is if you are diabetic outside of having polycystic ovarian syndrome, you might struggle to fall pregnant as it is, just because you have an underlying metabolic condition. The really important thing for Jamie to do is to make sure her sugars are very well controlled. If her sugar's all over the show and she's not great with her insulin, and her HbA1c, which is the measure that we check to see what the last 3 months have looked like, sugar control-wise, is not good, it is not a safe place to start falling pregnant. And we want that HbA1c level to be under 7, ideally under 6.5, for the health of baby. And unfortunately, you already got this issue of trying to ovulate, and now there's this autoimmune condition, because diabetes is an autoimmune as well as an endocrine condition on top of it, which can be a little bit more tricky. But we should be able to get you to ovulate if you are not ovulating reliably with the other medication, provided your sugar is well controlled.
Okay, great. Thank you. Then, Gynae, with patients with PCOS planning to do IVF, is it advisable to be on oral contraceptives preceding or leading up to IVF, or is it better to not be on oral contraception? Sorry.
So that is a controversial question. So at the moment in the world of IVF, we had this big publication by one of our big fertility bodies that looked at what is the effect of the oral contraceptive pill. Now, it depends what you're trying to get out of it. Now, one of the big concerns is there has been some data coming out saying if you are on the oral contraceptive pill for between 12 and 28 days at least before starting IVF, you might have a lower live birth rate. Now, that's not a pregnancy rate, that's not talking about a miscarriage rate, that's talking about take-home baby who is alive and healthy at the end of it. So we are concerned that maybe it might affect that. We also do know that being on the oral contraceptive pill drops a lot of the ovarian reserve markers. So when we're looking at the ovary, it might not look very polycystic. When we are doing your AMH blood test to check your egg reserve, it's going to be lower if you've been on the contraceptive pill. And there was a study that said it takes about 3 months for all of that to go back to normal. So there might be a bit of benefit in that if you're on the oral contraceptive pill beforehand, you might have less of an excessive response. But then we also have that data saying that you might have a lower live birth rate. So we don't exactly know what the right answer is for that. A lot of the times you're going to go on the pill to program your cycle. We don't have evidence to say that less than about 12 days is a problem. So there's nothing with you starting the contraceptive pill, taking it for about 10 to 12 days to induce a bleed. There's nothing wrong with that at all. The other thing that we always talk about is polycystic ovarian syndrome sometimes has a little bit of a higher LH level. So one of your hormones, the one that usually peaks when you ovulate, your baseline level can be a little bit higher. So when we give you the contraceptive pill, we often suppress that. Now, are we suppressing it to a point where it's good that it's lower? We don't know. The converse of that, are we suppressing it so low that just giving you these, where are my injections, just these injections, will that be enough? We're not sure. So we don't have a clear answer as to whether you should or shouldn't be on the oral contraceptive pill. And that's something that each clinic will have their own protocol on. From our point of view here, if it's for timing purposes, for traveling patients, or getting you to have withdrawal bleed, we don't mind, but we don't like it for too long. We don't give it specifically to try and drop ovarian reserves, because we are very good at trying to avoid hyperstimulation in our clinic. We're very experienced with the Leukin trigger here, so we're not too worried about that bit. So we don't routinely do it for all our patients with polycystic ovarian syndrome.
Okay, great. Okay, so I'm just going to do one more question, and the rest, if you guys can email Doctor, because we can't keep it too long away. Okay, let me just see which one. Okay, someone's asking Insumax. She is on Insulisha. She's on Insumax tablets. How good is it for me?
So the Insumax, there's going to be a lot of publications, but what I urge you to do is to have a look at those publications, because everyone always says to me, oh, but I've seen this study and that study, and ask yourself how many patients were in there, what was their control, so what were their control to, how long were they on the treatment for, and what was their live birth rate if there is one that is published. So there's a lot of data saying that it does help, that it drops your insulin levels, and we know that dropping your insulin levels does help with ovulation, and that it makes your body more effective with androgens, but we haven't seen the direct relationship with someone who's polycystic ovarian syndrome, takes Insumax and falls pregnant spontaneously. cannot tell you that's going to be the thing that helps you fall pregnant. It is not harmful for you to take. So if you feel that it's making a difference, if you're monitoring your sugars, if you feel that you're losing weight, if you're feeling more energized, then stay on it from that point of view. But I cannot show you the evidence that tells you this is going to be the make or break between falling pregnant.
Okay, great. Okay, so wow, we've had a long chat today. Thank you very much, Dr. Oosthuizen. If you guys want to get hold of Dr. Oosthuizen, you can contact the Cape Fertility Clinic. I will post details on our Facebook page as well as on Instagram. I'll put it in the comments, and then I'm going to be posting this video if you want to watch it later and go through everything again. But thank you very much, Dr. Oosthuizen. It was lovely having you, and we hope we can have you again soon. Thank you very much. Have a great day further. Bye.
You too. Bye.